Hi, everybody. Welcome to the January 21st, 2023 Blood Cancer Uncensored meeting with our first guest speaker of the year. And I thank everybody who's attending today. I am thankful for the leadership of Blood Cancer Uncensored. We have on the call Adrian, Sue, Lynn, and myself. Phil might join us later on. And I thank our attendees who make our group possible. We would be just talking to ourselves. You know what I say about that. And I'd like to present a special Ask the Doc event today as we host Dr. Shahzad Mustafa. Dr. Mustafa graduated from University at Buffalo School of Medicine and Dentistry in 2004 and has practiced medicine in the Rochester area for what I believe to be 19 years now. And he's currently the chief physician of allergy, immunology, and rheumatology. And was head of the team managing outpatient COVID therapeutics at Rochester Regional Health, as well as a clinical professor of medicine with the University of Rochester, also here in Rochester, New York, which is my town as well. So we do welcome him. And what we're going to do is we're going to ask you guys to put your questions in the chat. We're going to read them ourselves this time to give him the time and space. And then we might have a little like open chat afterwards if there's time. But I do want to introduce to you Dr. Shahzad Mustafa. Thank you so much for joining us.
Thanks, Lisa. Thanks for having me. It's my pleasure. I had fun the first time around, so thanks for letting me do round two, guys.
Thank you. And Adrian, I think you have the first question and you're going to ask it.
Yeah.
Thank you.
Yeah, hi. So thanks for being with us again, Dr. Mustafa. My question is around IVIG or SCIG, and for anyone on the call who doesn't know what that is, I'm talking about antibody replacement therapy, which can be given either intravenously or subcutaneously. And it's a bit of a multi-part question. I just wondered if you could just mention a little bit about what you think should be, the process of identifying who needs that from a blood cancer perspective. But for those of us that are on it, and I'm one, to what extent do you feel that this can protect against viral infections as well as bacterial? Because there's some discussion about that. But obviously, in light of all the data about antibody levels potentially helping with COVID, that's obviously of great interest to some of us, particularly as for those in America where Evishield is potentially going to stop working soon. And for those over here, we've never been given it. But I was quite personally excited the other day when the day after I took my my SCIG, which was probably a mistake, by the way, because obviously it would have given me a false high. But I got antibody levels of well over 2,500 for COVID, and so I thought finally at last it's filtering through in a reasonable quantity, at least to my batch of SCIG. Any thoughts about whether we should expect SCIG to help us protect us against COVID and flu and such like, as well as bacterial infections, and when we need it?
Great. So yeah, these are sophisticated questions. Thanks, Adrian. So immune globulin is just, my analogy is giving a diabetic who doesn't make insulin injections, right? So in individuals who are not making sufficient antibodies, immune globulin, whether it's IV or subcutaneous, can administer antibodies that you don't have to make yourself. Now, anyone with a blood cancer, CLL, lymphoma, myeloma, these are B cell cancers, and B cells make antibodies. So not surprisingly, individuals with blood cancer often have either low antibody levels or normal antibody levels that are dysfunctional. So if you have low or dysfunctional antibodies, you may benefit from having administration of antibodies exogenously with immune globulin. So who needs it? I think you need certainly individuals who are having recurrent, meaningful clinical infections. If you've been hospitalized for pneumonia, if you're getting antibiotics 6 times a year for outpatient things, certainly if you've been sick, hospitalized, sepsis, you deserve an evaluation. I think everyone would agree on that. I, as an immunologist, knowing that individuals with blood cancers have immune defects, think everyone deserves an evaluation, even if they're not having infection. It's information. It helps you risk stratify. It helps you better predict the future. We're not great at predicting the future. The problem with immune globulin, Adrian, is it's a very, very limited resource. It's not a medication. It's obviously antibodies donated by plasma donors. So we have to be very cautious about who we use it in. So in my opinion, in individuals with blood cancer who are having recurrent infections and have abnormal immune evaluations, it should absolutely be considered. I personally, there's a lot of nuance and a lot of predictors go into this. If someone is not having infections and they have a highly abnormal immune evaluation in a setting of a blood cancer, I personally do not jump to immune globulin replacement. And there's a lot of reasons for that, which we can get into if you want. But we try to treat people, not just numbers. And we understand a lot about the immune system, but we don't understand a lot about the immune system. So the numbers are helpful, but they're not the end all be all. And in my opinion, even if your antibody numbers look really paltry, but you're not having any infections and you're a 7-year-old with lymphoma leukemia, you're doing something right. So maybe I don't need to get too crazy or too involved, especially with a limited resource. I mean, immunologists call immune globulin liquid gold. We've had 2 shortages. At least I've been practicing for 14 years now, not quite 19. But in my 14-year career, we've had 2 nationwide shortages of immune globulin. So we want to be very cautious about where we use it. But that's who warrants it. Anyone with recurrent infections and significant antibody defects warrants it. But then it becomes debatable if you're not having an infection, if you're having infections and if your antibody levels are very, very low or you don't respond to vaccines. That's your first question, Adrian. I hope I answered it. The second question is antibodies primarily defend you against bacterial infections, but absolutely there is a role for viral infections as well. So if, how many are on this call? 20 people on this call. If you are already on immune globulin replacement, you are getting COVID antibodies in your product, almost certainly with over 95% certainty. Now, don't get me wrong, you shouldn't be starting immune globulin to get COVID antibodies, but if you're on it, you're being given COVID antibodies from plasma donors. So there is benefit with viral infections as well, but predominantly it's used to prevent life-threatening bacterial infections like pneumonia, sepsis, blood infections, things like that. How did I do, Adrian? Did I catch what you wanted?
Yeah, I think so. I mean, I guess my kind of question is, to what extent, should we be comfortable that those COVID antibodies we're getting are going to at least perhaps keep us out of hospital or whatever if we do catch COVID, or more keep the severity down? It's hard to know, isn't it? But
it's hard to know. There's no way to design a well-done study on that. But decreasing risk from COVID is not a magic bullet, right? There's multiple things that go into it. Common sense, risk mitigation, vaccination, even if suboptimal. There's no one on the planet who has zero response to a vaccine. Everyone has some response, even if it's suboptimal. In the US, maybe Evusheld until recently, maybe immune globulin. You add it all up and you try to protect yourself the best you can. Nothing is the end all be all magic bullet. So in that paradigm, I do think it provides protection. Can I say it's 10% piece of the pie, 20% piece of the pie, 90% piece of the pie? It's not 90% piece of the pie, but it's a meaningful piece of the pie in that, because if you're getting antibodies, you're getting other things in the human plasma that are, known to be helpful against infections. I think it's definitely meaningful. So I think it's reassuring if someone's already on immune globulin that there is added protection from COVID. It's not the end all be all, but it's additive, I think.
Can I just ask a little follow-up then on that with regard to some of these other things that you were just talking about? And I know we don't want to spend the whole time on COVID. So, Lisa, if there's another COVID question that this hasn't covered, maybe we can do that and then ban COVID. But I was just thinking about clean air, because this has been something that is becoming a little bit more interesting. I mean, maybe I'm being overly simplistic, but when the Victorians discovered that water was giving everyone cholera, they went around and gave everyone clean water. There doesn't seem to be quite as much desire to give everyone clean air, although we found in the UK recently, apparently a Parliament has just put really good quality HEPA filters into their aircon system. So they want to protect themselves, but like schools, hospitals, office blocks, restaurants, all of these places, shouldn't we be trying to ensure that the air is clean with either HEPA filters or ventilation or both?
I mean, I think that's an easy thing to say and agree upon, but executing it is where the challenge lies, right? What is clean? What's too much? What does a HEPA filter catch? I mean, HEPA filters aren't particularly effective for allergic stuff like aeroallergens, for example. How much ventilation do you need? And of course, all of this costs money as well. So of course, we would all agree that clean air is good, but clean is not binary. I mean, I always say that my kids get annoyed at me all the time that nothing's yes, no, up, down, black, white, left, right. There's always shades of gray. And I don't know what clean means. It's not going to be pure, but you don't want it full of diesel exhaust either. So somewhere in between. And does it have impact on clinical health? That's even harder to prove. You can be in, or there's just so much question there. So yeah, I agree with clean air, but executing it to a clinically meaningful way, I think is difficult, if not impossible.
Some interest in carbon dioxide levels as a proxy, isn't there? I think, but yeah, that's an interesting thought. I know
Depends
some
on what
people.
you're looking for. I mean, aeroallergens, there's lung disease, right? There's all sorts of different insults that can happen.
No,
It's
true.
super complicated, I think.
Yeah, sure. Anyway, is Lisa available to ask questions now?
I am available. Thank you. Those were awesome questions. Thank you for both of you guys for those questions and answers. All right, so we are on to our first regular question. This is from Evie. Evie says, is there a new vaccine in the works? I had the bivalent in September. So she's looking to hear from you, your opinion on what the best vaccine is in the works or what's available now. Thank you.
Yeah, I would encourage everyone to have their vaccinations up to date. And the most recent is the bivalent, probably in the fall. I'm actually not aware of any new vaccine formulations in the works at this moment. I'm not aware of it. I'm not fully plugged into it, but I'm pretty plugged into it. So I don't think there is right now, to be honest with you. But having it up to date, and the next question becomes, all right, if you had it in September, when should you get in the future? And I don't have an answer for that either. There's certainly no recommendations or guidelines to do so yet. So I would say if your vaccines are updated, sit tight. I'm not sure about what the future holds about repeat dosing or new variants. I don't think there's anything on the close horizon, actually.
Oh, thank you so much. Thank you so much. And that would be here in America that we're clarifying that because
Yep.
as we know, there's other vaccines available in other countries. So I'm on to Sally's question. So Sally says, I have CLL and see Dr. Awan in Dallas. Several in this group see an immunologist. Should I see an immunologist? If so, why?
Yeah, I mean, when you go to Midas, guys, you get breaks, right? You're talking to an immunologist, so I think we can add to the management of hematologic malignancies. I don't think you need to see an immunologist. I think you need to see a physician, oncologist, hematologist who is cognizant and able to evaluate your immune system and then intervene if needed. There are some hematologists, oncologists who know more about the immune system than I'll ever know. And if you're seeing them, you don't necessarily need to duplicate services. I'm appreciative of copays and multiple visits, and there aren't immunologists everywhere available. So if you have a hematologist, oncologist who is comfortable evaluating your immune system and managing defects, I think you're good. If you are with an hematologist, oncologist that's not evaluating your immune system, or if you have an abnormal evaluation to date and hasn't discussed options, you would very likely benefit from seeing an immunologist. And it's hard to say that. We all know for a fact, it's undeniable, no one would disagree, that everyone with a blood cancer has some amount of immune dysfunction. It might be very little, could be very significant. But recurrent infections are a huge problem in individuals with blood cancer. So we know your immune system is affected. So we can't ignore that. And I do, unfortunately, think we continue to minimize the importance of addressing immune defects in blood cancers because it remains one of the most common causes of bad outcomes. It's infection. So I don't think you have to see an immunologist, but I absolutely think you should be aware, cognizant of your immune system and potential ways to intervene if it's not up to snuff.
Very good. Thank you so much. And the next question that we have is from Sarah. And she says, do you have any comments on daily loratadine use to calm down itching and bite reaction?
Yeah, we're going from immunology to allergy. I like it. I think daily non-sedating antihistamines are perfectly reasonable to use on a daily basis. They should help with itching. They should help with bite reactions. They may help with sneezing, runny nose. In America, there's 5 over-the-counter second-generation antihistamines. And of the 5, loratadine or Claritin is actually the least effective. The second least effective is desloratadine or Clarinex. The most effective are either cetirizine or levocetirizine, which is Zyrtec or Xyzal, and then fexofenadine, which is Allegra. So Allegra and Zyrtec are more effective than Claritin. Those are the over-the-counter second-generation antihistamines available in the US. By second-generation antihistamine, I mean an antihistamine that is non-sedating, doesn't make you sleepy. I'm an allergist, and guess what drug I never prescribe? I never prescribe Benadryl, diphenhydramine. There's multiple articles now that Benadryl or diphenhydramine is an obsolete drug that shouldn't be used anymore. It doesn't really work better than the antihistamines I just told you, but it makes almost everyone sleepy, or it affects their central nervous system. So it's got a lot more side effects. It doesn't work better, and it only lasts about 4 hours, whereas the other ones last 24 hours. So Benadryl is a drug with no upside and lots of downside. So the Canadian Allergy Society has said Benadryl should no longer be available for purchase. There was just an article in Journal of Allergy, Clinical Immunology and Practice that maybe it's time to be getting rid of Benadryl. So I don't use first generation antihistamines, but second generation are safe and should help with the symptoms that Sarah was wondering about.
Wow, that's interesting about the Benadryl thing, is I
Yeah.
thought we used it on our kids to help them sleep better.
Well,
Oh.
yep. So now you're not using it as an antihistamine, right? You're
Right,
using
right,
it
right.
as a
Well,
sleeper,
yeah,
exactly my point.
And we use it on our pets too to calm them down before a veterinarian appointment.
Yeah.
So
you're
I'm gonna
you're
ask.
leveraging the bad side effects for Benadryl for good. And I would say if you're using it as a sleeper or to calm you down, there's probably better options out there. But
Right,
you
and
get my
just to
point.
follow up on what you said though, the neurological thing. So they're not saying that it causes neurological disorders, right? Because
No.
I do like to take it a little bit to
No,
help me sleep.
it doesn't. So the older antihistamines like Benadryl or hydroxyzine, Atarax, they cross your blood-brain barrier, and that's why they make you sleepy and they can change behavior. 25 to 50 milligrams of Benadryl, which is 1 to 2 tablets, which is a very typical dose, is very similarly equivalent to having 3 alcoholic beverages on a driving course. It absolutely impairs cognition, even if you don't feel it. So it's got very little upside, in my opinion. And for a guy who prescribes a lot of antihistamines as an allergist, Benadryl's not one of them.
Thank you. We really appreciate that. It was a great question too, as well as the others. Now I'm gonna have Sue handle her question just because she does explain it better. She wrote it all up and I appreciate that, but she's gonna ask the next question.
Yeah, it's just a little difficult to kind of write it all down. So I appreciate the chance to just say it out loud. Thank you. So I have CLL. I'm kind of 18 months past finishing obinutuzumab and about nearly a year past venetoclax. Obviously, it's taken a while for my immune system to pick back up. I do actually have a hematologist who's very active in checking my immune system. So I really appreciate what you said about that. So basically, I have very few B cells, although they're slowly recovering, but he says I have a good level of T cells, which is really good. I got through COVID last March after finishing treatment in February, so I'm really, really grateful for that. My IGs are still pretty low, but I don't have repeated infections, bacterial infections of any kind, haven't had any antibiotics, nothing. So I'm actually not a great candidate for IVIG, he tells me. But I have chronic kind of sinus issues, which I've had for about 9-10 months, been to an ENT. done various things, but they're very dry, they're very sore. I get nasal drip regularly and so on. I mean, I'm guessing that's related to a low immune system, but do you have any suggestions? The ENT suggested flushing and all that kind of thing. I did try an antihistamine for a while, but I just wondered whether it's kind of related and whether you have any suggestions.
It could be related, Sue. It sounds like you're doing great and you're in great hands. And even though your B cell numbers and antibody immune globulin levels are low, you're doing great. So that's kind of what we said earlier, right? We treat people, not labs. From what little I know, and I'm not commenting on your case alone, it sounds like the approach is right on. Sinusitis is a common manifestation of immune defects. But it doesn't know. It's hard to know if you're having sinusitis, like a bacterial infection, since you're not getting antibiotics. Or
I've had 2 sets of antibiotics; they did nothing.
Yeah, so probably not bacterial. No. So even though your immune system is suboptimal at this moment and recovering, it's unlikely it's playing a huge role in the sinus symptoms. Let's call it that. So what else can cause sinus symptoms? We all can get inflammation up here from a myriad of reasons, whether it's viruses, bacteria, or aeroallergens, or non-allergic triggers. But getting back to Adrian's point about dirty air, not clean air, non-allergic triggers in air, high ozone can cause inflammation in the upper airways, okay? So what won't work is antihistamines. Antihistamines are not anti-inflammatory. They're great for sneezing and runny nose and itching. They're not great for congestion, pressure, inflammation. The treatment of choice in the sinuses and upper airway for that is nasal steroids, which are very, very, very safe and well tolerated. And
nasal
steroids.
I've had some of those.
Didn't help much either.
No.
Those can be helpful.
It's really strange. I've tried lots of things that
those can be
various
helpful
people suggested
consistently. There are nasal antihistamines which can be helpful also. Some Astelin is a common one, inexpensive, universally available.
Sorry, what's that called?
Astelin. It's a nasal antihistamine, not an antihistamine pill. Astelin, azalastin. Old school medicine works fairly well for upper airway inflammation. And then there's some other tricks of the trade as well. So, there it might be nice to see an allergist. Maybe there's allergic triggers that you could address. But it doesn't sound to me like it's particularly infectious in nature, to be honest with you. From what you
I mean, it's not kind of thick and kind of blocked. It's just inflamed. I can tell it's just sore and inflamed, and it's just ongoing, and it's not something I had.
You have a good sense of smell, Sue?
It's not great. It's not.
So smell is a really, really, really sensitive question for people who have sinus inflammation. There's not many things that affect your sense of smell. In fact, allergies don't affect your sense of smell, really. So people who have decreased smell, we smell with a nerve called cranial nerve 1. It comes straight out of our brain through this part of our skull called a cribriform plate, and it goes into our sinuses, actually, this cranial nerve 1, the olfactory nerve. And if you have inflammation in your sinuses, you can have decreased sense of smell. So, Sue, I think you mentioned you saw an ears, nose, throat doctor.
I did.
It might be helpful to get a CAT scan of your sinuses, because there's ENT doctors do a nice exam with a camera in there, but you can't get to all the sinuses. And a very simple, quick.
I actually had a CT scan at the end of treatment, and that was when the thickened sinuses were kind of recognized.
So you have
it was picked up on my CT scan, but that was kind of back in April last year.
So if you know you have sinusitis, by definition, inflammation of the sinuses, there's some other treatments as well, some other medications. Short courses of prednisone can be helpful as well.
Yeah. Okay. No, that's helpful. Thank you.
Yeah.
I mean, I'm kind of waiting for my immune system to pick up properly after treatment as well. So I'm not ruling out that might help it too. No, that's helpful. Thank you so much.
Yeah.
Thank you. Thanks, guys. I have my own little question, and I probably could have looked this one up myself, but now I'm curious what you think, Dr. Mustafa. With the Evusheld, obviously it's on its way out, but is it good for anything else, for viral protection? Like, it's just only designed for COVID?
Yeah, so it's literally only a COVID antibody, so it's much more limited than something like immune globulin, which has other benefits to your immune system as well, probably. So
Okay, 'cause I was
Evusheld
on
is
the meeting. Yeah, I was on that meeting last week and everybody threw it under the bus.
yeah, I mean, it's really on its way out at this point, probably,
Yeah.
but it's really just one thing, and it's COVID antibody. It's a monoclonal antibody, so
Sure.
it does not have antiviral benefits or anything like that. I mean,
Um,
the beauty is it's safe and well tolerated. So
yes, and is it still hovering around 30%
it's
efficacy or is
still
it less than?
available in the
Okay,
United
well, no,
States
I
of
have an
America.
appointment. I have an appointment next week, so that's why I
It
asked.
is still available, and I mean, I'm not opposed to people getting it because again, it's fantastically safe and well tolerated. So if there's no real downside, and if the upside is minimal, still some maybe, I don't know.
Yeah, that's what I was hoping for. It's just I don't remember them giving percentages last week. That's why I was curious. Thank you. Thank you very much.
Yeah,
Um,
effectiveness is probably less than 20% of variance right now, probably
okay,
maybe less than 10 to be honest.
okay. Thank you so much.
It's small.
I was just certainly hopeful because I'm petrified of RSV, but well, yeah, and I'm gonna toss that in there. I'm one of the, I'm kind of in charge of the meeting, so I'm gonna add a question, but I read somewhere that you can really only get like RSV once. Is that really true?
No, you can get RSV more than once. RSV is just much more prone to affecting infants and way elderly. Even with immune compromise, it's not a common pathogen for immune compromised individuals. So it's certainly a big deal. In the United States of America, influenza and RSV has plummeted in the last 4 weeks. Huge peaks in November and early December, and it has plummeted since then. So that's good news. There's actually quite little influenza and RSV in communities in the United States right now.
Oh, that's good. That's very good. Thank you. Leora, I don't know if you saw my question. I can't scroll down on the chat, but did you want to do your questions? Because,
Sure.
okay, thanks.
So I guess my questions partly come out of the CLL Society webinar. When the question was asked about, or you and the other doctor were talking about kind of don't stay holed up in your house anymore. But I have two questions about that. Like first, there was reference, I think it was that there was a study somewhere in Scandinavia that found that the death rate among people with CLL was under 1%, but there was also a report at ASH where they looked at like 1,500 people who had CLL at 90 institutions. I think they weren't in the United States. It was mostly Europe, I believe. They looked at they used ERIC, so they were looking at medical records, and they found that like 45.8% were hospitalized, 8.1% admitted to the ICU, and 15.8% of them died. So it's confusing to me. So that's one question. And I'd love to see that 1% study. The other question and concern that I have, and I am doing a lot more than I used to. I do wear an N95 mask and I'm careful who I'm close to. But the thing that worries me, aside from getting COVID and not getting over it, which I have been told by an immunologist I am at risk for because I'm completely B-cell depleted, is since I didn't respond to the COVID vaccines, couldn't I just keep getting COVID over and over and over again if I do start going out in the world and getting exposed to it? And
Yeah,
I know
great
of
question.
people like, I talked to the nurse practitioner at my specialist's office. She's a CLL specialist, and she said that they have had patients who've gotten COVID like 2 months apart, and then they went back to being super careful. So those are my two questions. Like, how big is the risk for us? And what about just keeping on getting sick over and over and over? And that increases your risk of long COVID, and it's problematic for a lifestyle.
Yeah, those are great questions. I'm going to speak to the questions about the 1% number and the ASH study without speaking to specifics because I don't know them about the ASH study you're quoting, Leora, but I know how it works because we do a lot of research at our institution and we present at these conferences. ASH was in the first week of December. Anything presented at ASH was submitted for review in early summer.
Yeah, they covered January to May. That was the
There we
period
go.
that these
I
statistics
was
were for.
taking
So
us
it was the
back. So
first 5 months of Omicron.
so I've submitted in early summer. We're probably looking at data from early 2022. And it's going to be wildly different than now. So I can't speak to the specific numbers, but I know damn well for taking care of all folks like you locally. Last January and February was a real nightmare, and I had a lot of my patients hospitalized for extended periods of time. It was really rough, despite vaccination, despite monoclonal antibodies, despite Evusheld. So those numbers are jarring and disturbing. And we're in a very, 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 very different place. I don't have the exact citation for the 1% quote, but I do absolutely agree with it clinically. I've had several patients recently with CLL, lymphoma, myeloma get COVID in the last 4 to 6 months. Almost all of them have been treated with outpatient antiviral treatment, typically Paxlovid. And I haven't had someone hospitalized here in a really long time. So I don't have the exact mortality. And mortality, Leora, you're right. It's not the only thing. Death is not the only end game. Feeling crappy for a long time, long COVID, this all matters. But the outcomes have changed dramatically. And we have an 800-bed hospital that I work at, and inpatient COVID is a trivial part of that inpatient census right now. It's really not a big deal, to be honest, from an inpatient standpoint. So I do think there should be reassurance that outcomes have changed due to a myriad of reasons, partly just nature, and the virus, as it mutates, it almost always becomes less severe. It can become more virulent, but it typically becomes less severe because the deadliest viruses kill everyone and then they don't get to hang out. All they want to do is hang out with us. So they can't kill us all. So they're always trying to get past our immune systems, but they're not going to get stronger because there won't be any immune systems for them to hang out with. So this whole principle of viral mutation generally leads to less severe viruses over time. And that's clearly what's happening with COVID-19. So I do want to reassure you guys, and I was on the CLL, of course, Society webinar. I do like the idea of adjusting risk mitigation as the environment changes. Now you get to the question of if you're B cell depleted and you're not responding to vaccines and you get COVID and you get through it, are you going to build your own antibodies or have any memory from them? Good question. We don't know. Repeated COVID is possible, but clinically speaking, it's not something we see all the time. I haven't seen anyone who gets COVID every 2 months or anything like that. But again, there's a myriad of issues, risk mitigation strategies, things like that, but it is possible. But I would argue there's a lot in our immune system that we don't understand: T cell memory, T cell immunity, epitopes. And if you get a COVID infection, there are parts of your immune system that are adequately responding that will hang on to memory. I'm confident, even though I can't prove it with a lab test. The immune system is way too complicated for us to understand. We focus so much on antibodies, but that's really just one part of it. I mean, even T cells, we don't barely talk about because we're not smart enough to measure them well. So I'm confident when you or anyone on this line or us get COVID, there's a lot of things happening in our immune system to make future outcomes better. It's a very gestaltly answer, I'm sorry, but I'm confident in that. I do have a concern. There's a very, very small subset of individuals who get COVID who cannot clear it. Now this I have managed locally, and there is literature. Now this is like the unicorn. We're not talking, this is the zebra in the urban city. These are not horses. These are rare birds, but there are individuals who will get a COVID infection, may not even be that sick, but will not clear it and will remain symptomatic. And they're almost always immune compromised, often B cell depleted. They will test consistently positive, PCR, home testing, what have you. So that is something to be aware of, although the likelihood of that is exceedingly low. But I want this group is so sophisticated that you should know that is a possibility. I've actually seen more of that recently, which is a handful, than like recurrent COVID infections. And I
Well, one
mean,
thing,
population is biased. The handful I've seen was everyone kind of at our institution.
I
calls me
think
for
at
that.
Johns Hopkins, they treat those people, and I've been told by the ID doctors there, they are mostly blood cancer patients who end up having COVID for months. And if they're treating them with simultaneously with remdesivir and convalescent plasma from somebody who recently had COVID, and it's very high titer, and that's how they're ending up getting rid of it. But
They're
there's
doing
no
what everyone's doing.
established
I'm gonna be pathologically transparent. No one knows what the hell to do in that situation.
Yeah, they've said that, but that's working
Remdesivir,
for them.
3-day course, 10-day course, low risk, maybe it works. Convalescent plasma. People have gotten Evusheld in those situations. All sorts of stuff. If you're on any immunosuppression, like an oral steroid, trying to get that down, I mean, it's just a crapshoot. There's a lot of stuff you can do and has been done, but the science there is really poor. But absolutely, Leora, there are reports of it. There's strategies to address it. We've done it here. You get there eventually, but I'm smart enough to realize that we know so little sometimes that maybe it's just time that helps. Who the heck knows all these crazy interventions we threw at people? I have no idea. But absolutely a reported thing that you should be aware of, and I know many of you are probably. That's why I brought it up.
All right, thanks, guys. Thank you so much, Leora. That was awesome. Now I'm moving on to Barbell's question, which I'm going to read because it's nice and short and I understand it. It says, do all IGs get lower as you age or only the IgM? If they stay low, is it a matter of B cell function? That's a double question for you.
Yeah, your IG level does not necessarily decrease over age. Your antibody responses tend to kind of simmer down over age as we get older, but your IG levels do not need to necessarily decrease over time. Your IG is determined by a myriad of factors, guys. It's how much you make, but then how much you lose also. Immune globulin is a protein. So if your kidney function, which often declines with age, gets a little worse, you start spilling some protein into your urine. So even if your immune system's making all the antibody, if you're spilling some of it in your urine, your number is going to be a little bit lower. Individuals with Crohn's disease, diarrhea, celiac disease, you can lose protein in your stool. So there's a lot of factors that go into your IG level. It's production, but then loss also, and then meds and all the other stuff. So your numbers don't consistently trickle down over age, but there are reasons to believe that might happen. But we do know it gets harder to respond to antibodies as we get older. And by older, I mean, there's a wide range, but that's why Prevnar, for example, Prevnar pneumonia vaccine is often preferred to Pneumovax in folks over 65 because it's a little bit easier for your immune system to respond to that. So I don't think your levels always just get low with age, but there's a lot of factors that do affect your immune system with age, and advanced age does have some inherent immune deficiency, just like little babies do. Life comes full circle.
Seems it doesn't. Except when you have CLL, I think that's why we ask these questions. We're a little wonky about this stuff. Thank you, Barbell, for that question. Now I'm on to Jenny's question. Jenny says, welcome, Dr. Mustafa. I have read about a study by Jay Schluter, which you may be aware of. Nod your head if you are. No? Yes, no?
No,
Oh,
I might be.
It says, but of which studied patients needing bone marrow transplants after all their immune cells had been destroyed during treatment. Stool samples were studied and changes in microbes compared to changes in white blood counts. It was found that certain microbe species were central to restoring white blood cell to normal levels. Could the gut microbiome be as important as stem cells in the bone marrow in producing the right amount of immune cells in circulation and lead to changes in treatment in future? And Jenny, if we get any of this wrong, can you chime in and help us out, please? Because I didn't realize that was so long. I'm sorry.
No, that's fine. I'm sorry it's a long one. It's just I felt I had to explain it. Sorry.
Yeah, I think the answer here is, could it? It could. Do we know if it does? Heck no. Is it more important than the bone marrow? I don't think so, but what do I know? I mean, there's tremendous research being done right now in the world of the microbiome, in the world of immunology, cancer, GI disease, neurologic disease. I mean, fecal transplant, stool transplant from one donor to another is now approved, now FDA approved in the United States for recurrent infection with C. diff, which is just GI infection. So that's an FDA-approved product. Fecal transplant is being studied in a host of things. It's being studied in type 2 diabetes. Fecal transplant is being studied in multiple sclerosis. So we know that the microbiome, the bacteria and the viruses and the fungus, all these microbes that we live with, probably about 7 trillion on each of us, have a huge part in determining our health. They're not just innocent bystanders. But the question becomes how to manipulate your microbiome, how to affect it to affect human disease. And we are very far away from that. But again, in med school, which was not that long ago, it was less than 20 years ago, we never even talked about the microbiome. And now it's a big, big, big point of research in the last decade. And if you Google microbiome, the number of hits that have come up in the last 10 years, it's just like a straight line up. So fascinating area of research. I think we know very, 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 very little about it. But it 100% plays a role in human health. What that role is remains to be determined.
Thank you very much.
Thank you for that
If
question.
you guys are interested in microbiome, there's 2 great authors that have great books that are very reader friendly. They're not heavy science. One is Susan Prescott. She's from Australia. I forget the title, but if you Google Susan Prescott, Australia microbiome, she writes she makes her own art too. She's a wonderfully talented woman, physician, immunologist. And the other is Maria Ariada. She's at the University of Calgary and has some great, easy to read books on the microbiome.
Thank you.
Could Seymour, I have a feeling Seymour knows about this. Can you post that? Because I'm having trouble typing about Susan Prescott. I have a funny feeling we've talked about these ladies before. If anybody knows about that and can put it in the chat, that would be great. And actually I'm on to Seymour's question. I'm sorry, oh, thank you. Is that an accident? Dr. Mustafa, are we good for a little bit? Because it's almost 3 o'clock. Are you okay with staying a little bit? Because
Yeah, I'm gonna have to leave probably by about 3:10 or so, but yeah, I'm good right now.
okay.
If that's okay.
No, yes, no problem. So I'm just scrolling back up. It says, so Seymour is interested in wondering what it means to have exhausted T cells and whether tests such as flow cytometry might provide a clue about exhaustion.
Yeah, this is a little bit of a vague terminology. I mean, it's alluding to decreased T cell function. T cells are hard to measure because they're very dynamic, so we can check them with flow cytometry. Seymour, the numbers. Functional assays are really hard to do, so flow cytometry is not as helpful regarding T cell function. It gives you a better idea about the numbers. So, there are conditions where your T cells can be less effective. Obviously, certain medications, systemic steroids are the most common. I think that's what you're alluding to with the concept of exhausted T cells. But flow cytometry will give you the number of T cells, which will be decreased with certain things like oral steroids, but it doesn't speak too much about the function, which is really hard to check. Just like for antibodies, we check levels and they can check vaccine responses. You can actually do that with T cells too for other, almost like a PPD on the skin. You can check PPD responses are T cell dependent. So if your T cells aren't working, you won't be able to do like a PPD or response like that. So that's the best way to evaluate it, but it's really hard to do well.
Oh, okay, thank you. And then a follow-up question, also from Seymour. It says, if I failed titers on Pneumovax 23, it didn't make a good response to, COVID, spike, IgG. Should I skip the Shingrix vaccine and do daily Aclivir or Valacy Clovir? And there was a question also saying, should we get the Shingrix shot? So we could maybe handle both of those. But it says, should I skip Shingrix vaccine and do daily Aclivir or the Valacyclovir? No, I got it.
Yeah, no, I would recommend staying up to date with all vaccination recommended vaccines. I mean, again, the response is not binary. Your response may have been suboptimal by measuring the antibodies for pneumonia or COVID, but there's probably some T cell immunity, other immune response too. And I think same for Shingrix. You may not have a perfect response, but you probably have some response. So I would continue to encourage everyone to remain up to date with all recommended vaccines, even if you know the response may be suboptimal, because vaccines are so well tolerated. I mean, immediate side effects are minimal and manageable. Long-term side effects are very, very, very rare. So I think the benefit still outweighs the risk.
Nice, thank you. Apparently, there's somebody here that would like you to try to work the juice is worth the squeeze into one of your answers. Okay, just remarking on that. I'm trying to find the next question, but that entertained us quite a bit the last time.
So for
Alice is
vaccines, I
asking,
think the juice is worth the squeeze because the squeeze is not hard. There you go. I can always work it in.
and Alice, who actually is in Florida and understands about oranges, says she asks if she is worried about shingles. Did we just answer that though? She's been worried about the shingles shot for a long time because her oncologist is not pushing it because she has CLL, but her GP would like her to get it. It says that it was tested on CLLers and was not effective and would not suggest getting it. And I've heard that people get very sick after getting it. So if you want to take that question, please.
Yeah, you guys, I feel like I'm beating a dead horse, but careful with the words. I pause before saying something's not effective, right? It's probably decreased effectiveness in CLL, but there's probably still some effectiveness. People get sick after it. Yeah, I mean, after any vaccine, you may feel unwell for a short period of time, but side effects are minimal, well tolerated, and long-term complications are on the order of 1 in several thousand injections. So I continue to believe in vaccination, not only in all populations, but particularly immunocompromised populations, because even if you're not responding as well, I want to give you as many layers of risk mitigation against the infection. But we talk about it with COVID all the time, but disseminated zoster is a big deal too. So I would continue to encourage staying up to date with all recommended vaccinations, even if the response is suboptimal. I don't think the response is going to be zero zilch, like your body never saw it. I think it's hard to believe.
Thank you very much. And there is a test for that, you've told me, but I don't know if generally doctors would allow us to test our.
We have tests, yeah, we can check antibody levels to a lot of the vaccines, and we do that. But there's so much more to it. Again, our ability to evaluate for vaccine responses is not as good as we want it.
Cool, thank you so much. Our next question is from Esty, and Esty just wants to know, what is the best test for food allergies?
I'm going to sound like a jerk, but the best test for a food allergy is taking a really good history, not any test, asking what happens after you eat a certain food. Food allergies are 100% reproducible reactions that almost always occur within 20 minutes of exposure to a food. So that's the best starting point. Once you've taken a good history and have some question or concern about a food allergy, there's skin testing and IgE levels. Not IgG or anything else, not a whole host of other non-validated tests that are available. So take a really good history. If you think there's a concern for food allergy, consider a skin test of the food or IgE levels for the food. No other tests are really validated.
That's awesome thing. And you know what, guys? I think that we did reach the end of our questions before the 3:10 deadline, the 10 after deadline. It's pretty amazing. Oh, wait, Jerry. Okay, so Jerry just put a question on.
And I also do see, by the way, that is the book from Susan Prescott. Thank you, Seymour, Secret Life of Your Microbiome.
I knew that. I'm pretty sure he's a big fan. Okay, so Jerry just posted a question that I think is good. And Jerry is in the United Kingdom and says, what is the most difficult to explain, immunology or rules of test match cricket?
Depends on who you're asking to explain it, Jerry. I used to play a little cricket back when I was, I'm from Pakistan originally, so we would go home when my grandparents were still alive, go back to Pakistan in the summers and spend about 4 weeks there. So every day around 5 o'clock, a little cricket on the streets. But I sure as heck don't know the rules of test match cricket. I love it.
So Jerry, you're gonna have to be our special guest next time, I think, actually, and you can explain that, because I think you know. Also, so Barbell wants to know, and there was another question that I skipped for a moment, but Lynn asked, and I'm gonna combine it with Barbell's question. Lynn asked, how long should you wait after having long COVID to get another COVID vaccine or a bivalent vaccine? And then Barbell wants to know how long you should wait after you've had shingles to get Shingrix if you never were vaccinated for that as well. Is there any way you can take those kind of combined?
Yeah, I mean, you can be vaccinated with any vaccine where you're not acutely ill. So there's no hard and fast rule. I tell people once you're not febrile and feeling relatively normal, you can be vaccinated. The counterpoint to that is if you just had an infection, you potentially built your own antibodies, you can wait a few months before you get vaccinated because you already have your own antibodies, so you don't need to build more. It's kind of a made up recommendation, not heavy science. There is a mention there of long COVID. There is good data that someone who has long COVID, you could potentially abbreviate or abort the symptoms with vaccination. So for people with long COVID who have not had a vaccine in the recent months, rather than waiting, I would actually encourage vaccination because it may actually help break that cycle. There is some literature to support that. So there's no, once you're infected, once you get back to your baseline, you're not acutely ill, you can receive most any vaccine at that point.
I think that's really sound advice. And I throw it again in a plug because of the question from earlier about Shingrix. Is I had no side effects from Shingrix. I was not ill. I had Googled it before I went in, and I thought, oh, the humanity, I don't want to do this, I'm going to die. And I was not sick at all from either series. And I have CLL, so I don't know what the hublue is. Just remember, everything we read on the web is usually just everyone who complains. I work in an industry personally where nobody ever calls up and thanks us. They pretty much just complain. So just remember that when you guys are searching the web, that's your little disclaimer on that. It is 3:05 and I do see Barbell. Yeah, I'm not asking that question, Lynn. Do you see Lynn's question?
Oh, yes. I think
was,
I have to go. I'm over time here.
Well, how about this, guys? Just because so Dr. Mustafa, I mean,
Let me comment one more thing. The other book, by the way, sorry, from Marie Arrieta, it's Arrieta. It's Let Them Eat Dirt. Also a really good read. Yeah,
I've heard of
those
this
are the
before.
two.
This has come up before. I'm sorry, Barbara, I'm just gonna hold off on your question, but it's basically, a year ago we met approximately, I think it was March or April, and things were a little bit different. Our main concern, the reason this group formed is because we have blood cancer and because of the COVID-19 pandemic. But I know things have, I don't know what you would say to us, because you've always been a great advocate for us. What would you say now about things? What's your opinion now?
Yeah, I mean, it's my opinion. I know my personality hugely affects my opinion. And I am an eternal optimist. I think we've made tremendous progress. I think we've made tremendous progress. We've got a long ways to go in learning our immune system, why people get recurrent infections and what to do about it, but in COVID as well. I really, really think today, January 21st, 2023 is wildly different than just a mere 12 months ago. Wildly different. My own sister, she doesn't have blood cancer, but she's highly immunocompromised. And this was echoed on the CLL webinar too, society webinar. Like, I do think it's very important. The only outcome from COVID is not just mortality, which is pretty low. I mean, everyone has been affected in their quality of life. Mood disorder, depression. It's a real thing, and we cannot minimize the infectious consequences of COVID. So I think it's very, very important for individuals to socialize, to spend time with whoever you wish to spend time with. If you want to spend time with no one, more power to you. But it's important to have these important interactions with loved ones, family, friends, children, grandchildren. And I encourage people to do it. Someone mentioned, alcoholism. I mean, there's all sorts of data on suicide rates, teen suicide, depression, alcoholism, all of this has been affected by COVID. So I encourage people to take common sense risk mitigation. I encourage us to kind of start to reacclimate in the world that you're comfortable with. You don't need to be doing things you're not comfortable with, but things that you wish to do. Start taking baby steps, because this is not going anywhere. It's possible to lock down for a week, a month, 6 months, but not for a decade, or whatever it may be. So I'm the eternal optimist. I think we have good therapies, despite having suboptimal immune systems. Individuals with blood cancers or outcomes are remarkably better now than they were just months ago, and they're going to continue to improve. So encourage you to kind of live life to the fullest, to your comfort level, because doing things that you're not comfortable with is also not good for quality of life. But if you're comfortable and it's important to you, I think it's time to pick and choose things. And that's what I've counseled. And I think it's gone well. Anecdotally, I don't have research on this, but for my patients who I manage here, they've done very well. And what I tell them they can or should consider doing today is very different than a year ago. You guys are wonderful advocates for this whole community. So thanks for everything that you do. I mean it. You guys are as responsible as any of your healthcare providers for this community. So thank you so much. It's such a privilege to get to hang out with you.
Thank you. Thank you for doing that. You basically hung out with the world. And I thank you very
Thank
much,
you.
guys. Let's take our mute off and give them a hand around.
Thank you.
We can clap
I
on Zoom.
appreciate it so much.
Thank
I
you very
look forward
much.
to doing it
and
again. I
you're-
hope everyone has a good weekend, and maybe the sun will shine here wherever.
It
all of
will.
us
It's above the clouds. It's up there. All right. Thank you so much again. We'll
Take
see
care,
you.
guys.
We'll see you later.
Thank you.
All right. Bye-bye.
Thank you.
Thank you.
Just a minute. I have to stop recording. Okay.